Hello, everybody, and welcome to E-QIP webinar on QI myth busting. Just going to give another moment for latecomers to join the meeting, and then we'll begin. All right, hello, everybody, and welcome to our E-QIP webinar on quality improvement mythbusters. I feel like we need a theme song for this one, like a Ghostbusters, the Mythbusters. And we're going to talk about some common misconceptions regarding quality improvement with community mental health and addiction agencies, and try to bust some of those myths that may be lingering out there around QI. So on the technical side of things, hopefully you're able to hear and see the screen, the PowerPoint screen. And if you have trouble hearing us through the audio on your computer, you can dial into the phone number that's on your screen, and you can hear us over your phone and watch us on your screen. There's also a question bar on the GoToWebinar control panel, and feel free throughout the session at any time, type in any questions that you might have into that question bar, and we'll make sure to get to those. You can also minimize the GoToWebinar menu bar by clicking the little orange arrow at the top, and it'll get smaller so you can see the full screen. And as always, all of our webinars will be recorded and posted on our Community of Practice and YouTube channel for future reference, along with all of the slides and handouts that we talk about today.
Slides aren't advancing.
Oh, apparently the slides are not advancing. Let me see here. Oh dear. Sorry, folks, technical issues right off the bat, so I'm going to try and see if we can't make sure that everything's advancing properly. Why is that?
Can you go to the audience view? The first tab.
Okay, hopefully the slides are advancing now. You should see one that says, please let us know how many people are with you in the room today. So hopefully you can see that. It looks like it's showing up on my screen. So if you could, just let us know how many folks are in your office or wherever you are watching this webinar so we can get an accurate number of the participants today. So the goals for our session today is to identify some common misconceptions about what quality improvement means for the community mental health and addictions sector, and clarify some of these misconceptions or myths based on the Model for Improvement, which is a global framework for quality improvement work in healthcare settings. And hopefully we'll also, at the same time as busting these myths, motivate you by sharing some learnings and experiences as to how the Model for Improvement can be used successfully within our sector. And we'll share a couple of examples as we go through the day. We're going to use a fictional example as a bit of a helper as we move through the different myths. And this example is going to be called the Live Well Recovery Services. And the scenario sort of comes on is based on a compilation of common misconceptions around QI that our team of coaches have heard from the sector that during their coaching. So we've tried to compile that into an example that'll hopefully resonate with you and your work. So delivering this session is myself. I'm obviously Michael, not Jenna, and I'm Director of Quality Improvement at CMHA Ontario. And co-delivering this with me will be Jenna Hitchcox, who's our Program Manager here at E-QIP. And as always, for those who maybe aren't as familiar with E-QIP, E-QIP's a partnership initiative between Health Quality Ontario, Addictions and Mental Health Ontario, and CMHA Ontario to help support the community mental health and addiction sector in the area of quality improvement, and building off the sector's already very strong commitment to providing the highest quality of service possible to the clients and families who come and ask us for help. And we do that through offering a number of training and educational opportunities, as well as through quality improvement and data coaching, which you'll hear about at the end of this webinar. So our example that we're going to be working with today, as I mentioned, is the Live Well Recovery Services. And Live Well Recovery Services, our fictional organization, recently went through an extensive accreditation process for the first time and received exemplary status. The executive director, board, and staff members worked hard to ensure that accreditation was achieved. Since receiving this high status, the agency staff believes that the care they provide to their clients is of high quality. The accreditation process came with a lot of small-scale suggestions for ways that this agency can continue to work on items assessed through the accreditation process. For example, it was recommended that a new process be put in place for tracking individuals that are deceased but remain in the agency's client database. There is also room to improve the degree to which clients are involved in shaping job descriptions for staff, as well as enhancing opportunities for clients to be involved in program evaluation. Staff want to take these suggestions on as quality improvement projects as the year progresses to improve care for the clients they are serving. So that brings us to our first QI myth of the day, and that myth is we're an accredited agency, so we are promoting a culture of continuous quality improvement across our services and programs. I don't know about you, but we've heard this one before. Sometimes accreditation gets equated with QI and being a culture of QI. So the myth is busted. We need like a sound effect for that, I think. Some kind of busting sound effect, I don't know. Accreditation provides foundations for quality improvement work, but does not equate to improvement in client care and client outcomes. So while it provides us with a very nice framework and helps guide us to maybe develop a quality improvement plan or to take on quality improvement, it doesn't provide the granularity to actually make those quality improvements happen related to the client service that we do. It can help facilitate improvement, but true QI is a commitment and ongoing focus on client outcomes. And that requires a lot of work. We see it happen sometimes where folks will go through accreditation and then things can lapse in that 4-year cycle until the following accreditation. And the initial interest or momentum to take on quality improvement can sometimes fall away. So accreditation doesn't necessarily equate to being truly a quality improvement organization. So what is accreditation? Well, accreditation is an ongoing process of assessing healthcare and social service organizations against standards of excellence to identify what is being done well and what needs to be improved. Accreditation is important because it helps create better healthcare and social services for you, your family, and your community. It allows organizations to understand how to make better use of their resources, increase efficiency, enhance quality and safety, and reduce risk. And there's a lot of resources available, and there's a link there to one that you may want to check out around accreditation. So on the other hand, we have quality improvement. And quality improvement is really a systematic approach and commitment by all involved to continuously strive to make and sustain improvements in the delivery of client service. And that ongoing commitment will help lead us to better client outcomes and better health, stronger system performance in delivering care, and enhanced professional development. And it really is an ongoing, continuous process and commitment from everybody, from all the way from boards and senior leaders, all the way down to frontline staff, volunteers, and clients. And this is what it can look like. These are 3 models that we come back to quite often in E-QIP. And we all want to get to that place of that quadruple aim, and that's providing the best care we can for individuals and families and doing that at a low cost. But to do that, we need to be continuously working to improve those domains of quality, those things that clients and families tell us are important, having safe, timely, equitable service, etc. And to do that requires an ongoing mindful attention to how we're doing and how we can improve. And that's where that model for improvement comes into play. And that is in the daily workings of looking and reflecting on how we're doing relative to those domains and where are the opportunities to do a little bit better. So with that, I'm going to flip it over to Jenna for our second QI myth.
Okay, so this next scenario are 2 situations that the Live Well Recovery Services is finding themselves experiencing. And the first one is about their mutual clients between their own organization and services and the hospital that's in their community. And they're finding that the individuals that are being admitted into the hospital are, from their perspective, being discharged too early, which is leading to readmissions within days or weeks of being discharged from that acute care setting. The second situation is that they have a court support program, and they're finding that clients are entering into the justice process, and they're often ending up in crisis when they arrive at a correctional facility. And the staff aren't too sure what the problem is within that setting, and what the staff are or are not doing to ensure that clients don't go into crisis, but they're not quite sure what their role is in ensuring that that doesn't happen with the clients that they're supporting through the justice process. And so the myth here is really that there are system issues that impact mutual clients across organizations and across healthcare settings. And in many cases, like the justice example, it might not be what we think of as a healthcare setting, but healthcare is provided. And often providers in the community-based setting, as well as in other sectors, feel that the services that clients are getting in other settings aren't up to par, and that the staff in those organizations are to blame for the issues that the clients are experiencing when they're not under, their own roof and getting help within the community-based care. And so quality improvement is really about thinking that beyond the blame game and beyond thinking that the care that clients are getting are, if we believe that it is subpar or not serving the clients well, that it's the staff that really are to blame for those things happening, and for those discharge folks to be readmitted. There must be something going on with the staff in that organization, or there must be something going on with the staff within the correctional facilities that isn't serving the clients well. And so that thought is fairly pervasive across healthcare settings, as we find when we're talking to providers. But there's also that blame game that happens within an organization as well. So if a client isn't getting further along in their recovery journey and becoming more well than when they started, we often want to play the blame game and blame individuals rather than the systems that they're working in. And so quality improvement really encourages us to think beyond those individual experiences and makes us think about the systems that people are working in, and what are the systems that are at play here that are impacting the way that service providers are able or not able to do their jobs well. And so we encourage people to think about, and the model of improvement encourages people to think about the root causes of issues. There may be some that stem from providers themselves, but there's also a whole host of other system factors that come into play. So there's things going on with clients, there's processes that are in place, there's policies, environments, technologies that are all impacting the way that we're providing care. And so quality improvement really encourages us to think about that and to move beyond blaming individuals or other organizations for clients falling through the cracks and not getting the care that they need. And the last point on this slide is all about the Advanced Learning Program run by IDEAS. And IDEAS is a partnership program from the University of Toronto and Health Quality Ontario. And we'll talk a little bit more about at the end about how you can get involved with the program. But they're really set up to work on quality issues that do cross those organizational boundaries. And they encourage teams to apply with more than one organization across Ontario to help those issues that do impact clients that are getting care from more than one provider. And so there's really great examples that come from that program.
Speaking of the blame game, I just want to check in and make sure there's no technical issues on the screen. We had some challenges with things freezing up a bit, so I want to make sure that we haven't lost anybody. So if the slides are not advancing, if you could just let us know in the comment box. Otherwise, we're assuming that everything's A-okay. All right. So our next myth is that we feel we have a good clinical relationship with the clients that we work with, so we understand that quality means to all clients. We don't necessarily need to improve anything. And in our example of our Live Well recovery services, the staff there feel they have a very good, close clinical relationship with the clients that they work with, and the clients often express what their needs are and work collaboratively with providers to create a plan of care to meet their goals. They also have an annual client satisfaction survey, which demonstrates high satisfaction with the care they receive. And they also have a complaints process, and complaints are taken directly to the executive director of the agency, who then calls the clients who complain to understand what happened and the reasons for the complaint. And they then work with the individual or small group to try and address those complaints so they don't happen again. So that can be, I think, a pretty common myth. We understand we have a good relationship with our clients. We maybe can overgeneralize sometimes. So the E-QIP team has done some work to try and bust this myth. And what we found is that it's often best to involve clients in the quality improvement projects that we're taking on whenever possible, and try to break out of some of those assumptions that we know and understand the experience that people may be having from our services. We know it completely when it's possible that we don't. There there may be questions that we're not checking in or not asking regularly about that experience to get a full picture. And what we try to encourage folks to do in quality improvements is to be curious and continuously curious in how we're doing and what that experience is like for clients and families. And you can think back to those domains of quality, the safety, effectiveness, timeliness, etc. And wanting to understand, relative to all those domains, what is that experience like for folks? It's also very helpful to think about any quality improvement project, how to involve clients and families at every stage of that quality improvement project, all the way from maybe it's setting up our team to do QI and involving some clients or past clients on that quality improvement team, or maybe it's doing different exercises during the project to capture the voice and experience. But that entire process can be very helpful to think about how and where you might be able to involve clients and family members. And an additional resource that may be very helpful in terms of quality improvement projects is experience-based design, or EBD. And it's a set of tools that can help leverage and understand how clients are feeling through the process that they may be experiencing at our agency, and where those opportunities are to improve that process. So it very much takes a bit of a walk through the feelings that an individual or group of individuals may be experiencing while they're accessing that service. And we did a webinar earlier on EBD, and that's available for you if you're interested to watch that. And I'll walk you through some of those tools that may be very helpful. And one reflection question that we encourage folks to think about is, where do sources of client information feedback come from in your agency to identify quality issues? Is it through complaints, incident reports, surveys? Where is it that you get that information from? Those can be great sources of quality improvement. So with respect to our client complaint process, client complaint processes can be a very important way to flag areas for improvement for an organization, but can be very case specific. Quality improvement is about looking for trends in the experience. So not trying to pick apart and point blame necessarily, but looking for maybe common areas where folks may be having a bad experience or making complaints. And how can we learn from those trends and those complaints to improve that process to make it even better? And we can always get better. We're never perfect, I don't think. So there's always opportunities that we can look for. And so another reflection question is, does your agency have a system for reporting complaints to the board and for those to be reviewed, look for things like trends, etc., to understand how we're doing and where we might improve? Another helpful tool that you may want to think about is the process map. And that can be used in two ways when looking at a complaint. One, looking at the actual complaint itself and understanding the process that the client was experiencing when that issue happened, but also in understanding our complaints process. So how does somebody lodge a complaint? Where do they lodge a complaint? And what is the process that is followed to make sure that that complaint gets tracked and addressed and communicated back to that individual, and any changes get put into action? So it can be neat to walk through a process map to understand your complaint process. So when we thought about our example of LiveWell Recovery Services, they mentioned that they do a yearly client satisfaction survey to get experience. And this is a common theme that we've experienced with E-QIP, and that is that sometimes we do a satisfaction survey once a year, we can get glowing results of that survey. And the assumption can be that we're doing everything great, and maybe there's not opportunities to improve. And what we've learned through working with the sector is that we want to try and hit two types of feedback around experience. One being breadth, so wide span surveys, things like our OPOC questionnaires can be great at getting a large number or large breadth of surveys reported back to understand the experience from a lot of people who access our services. And sometimes those can give us little red flags of where we want to maybe hone in and gather more information, but we want to couple that with depth and trying to understand deeply that experience of receiving service. And what does that look and feel like and mean to clients? And sometimes you can take those red flags from our big survey questionnaire and then use depth tools to get deeper into that experience, maybe through a focus group or observation or shadowing, but looking really at understanding more qualitatively what that experience is like and where are those opportunities for improvement. So move it back to Jenna.
Okay, so the next scenario is all about resources and time to do quality improvement. So the fictional agency here does not have dedicated staff time to lead and drive quality improvement across the organization. They also had a data staff person that used to do the data entry and generate some reports based on that data, but that staff member no longer works there. It's been 5 years since they've done that work, and the person that took over didn't take over that role. And so as a consequence, the agency does not have any historical data, or only has historical data, but they have nothing current. And so the organization really has motivation and they understand the value in quality improvement, but they're not feeling that they have the time and the resources to be able to put into it. And so the myth here is a really big one, and one that's often heard from the community-based sector, is that we can't start quality improvement initiatives and projects because we have limited resources and we don't have a staff person to lead the work. And so we'll buzz this myth through a series of slides, and I'm hoping that what comes out of the next few slides for you is that quality improvement is really everyone's responsibility. And though it's lovely and there are organizations that have quality improvement leads to drive that work forward, it shouldn't just be that person's role to do quality improvement. It really is the role of the whole organization at all levels, as well as our responsibility to engage clients and family members along the way. And so improvement work can happen with limited time and resources. And the model for improvement really encourages you to diagnose an issue before you start testing some solutions and change ideas to make sure that the time that you are dedicating to quality improvement is used most effectively. And so that is something that is fairly strongly encouraged with the teams that we work with, but also across healthcare. Quality improvement and the model for improvement particularly is all about ensuring that we are using our time effectively. That's not to say that quality improvement doesn't require any time. It certainly does, and we don't want to give you the impression that it doesn't, but it's about using that time well. The model for improvement also calls for us to start small. So if we want to embark on a quality improvement journey, it's not about fixing all of the quality issues at once. It might not even be about fixing a quality issue that's facing the whole organization. We might want to narrow in on a certain service or program. So for example, wait times. We might not want to tackle wait times for the whole organization first. Perhaps we want to narrow in on wait times for a certain service or program. And I'll just let Mike talk about an example of starting small from the north.
Yeah, I would just, I hope the team doesn't mind me sharing this, but we were doing some work with a large group up in the Kenora Rainy River region to work together as a network of providers to tackle an important issue in that community, and that is the transition between a hospital-based and inpatient and residential programs and outpatient community-based programs where folks are living at home. And there can often be some challenges, I think, for most regions in the province at navigating some of those transitions in care. And so if you ever have a look at that region, it is massively huge. and to take on a quality improvement project that would address all of those transition points across that entire region would probably be an exercise in frustration, because it would be very time consuming, very elaborate, and very hard to see improvements. So what the team decided to do was to start small and tackle one transition point between one residential program and the community, and start there, do some diagnostic tools to understand what that process looks like, what are some of the challenges and potential opportunities to improve that, with the goal being to learn from that small project and eventually start to spread to other transition points within that region. So starting very small and using those learnings to guide future improvements.
Great. And the last point on this slide is the IHI, or the Institute for Health Improvements, framework on improving joy in work. And IHI is based in the US, but they're really a global voice for quality improvement in healthcare, and they release a lot of great reports and resources for learning about quality improvement. And so this framework for improving joy in work is really all about engaging frontline and management staff that are providing services in quality improvement work, so that providers can see how these efforts are actually improving outcomes for their clients. And the theory is that this will lead to higher satisfaction in providers if they're fully engaged and they're finding meaning in their work and in their quality improvement efforts. So just wanted to flag that for you as a resource at this time. So we just wanted to take a minute to ask, for those of you that are on the line, who in your organization is the quality improvement person, or the person that may have that assigned to them in their role. It's helpful to know their title, and if no one is that person in your organization, it's helpful to know that as well. And then I'll just talk about kind of what we're hearing from those on the line. So I had a question. Do you want the name, not the name of the person, but perhaps the title of the individual that has that in their role? Yeah. So there's a QI coordinator that's come from one. The executive director in another organization is the lead on that. Senior director of clinical services is another. I'll give a couple more minutes for folks to type in. Manager of Quality Improvement and Communications, the Director of Quality and Continuous Improvement. Great. So that's a fairly common, kind of breadth of what we hear when we ask about in the community sector who is responsible and who has that as the lead within an agency. There's larger organizations that will have someone likely with quality improvement in the actual title. And then there's smaller organizations where it is kind of a senior manager or an executive director that is responsible. And that's fairly common of what we hear. And so with that in mind, and taking into account your own roles and your own size within your organization, we encourage you to think about this slide. And as healthcare professionals, we have two jobs at work. The first one is to provide the care, and the second is on improving care. And the providing care, we're fairly strong at, and that's what you do in your daily work. It's providing direct contact with clients and care for clients. It's also about some of those administrative tasks that have to happen to make that work happen. But we're also thinking about improving care, and we often don't set time aside and think about, in your own practice, how you're improving the services that you're providing, but also at an agency level, what are some things that you're noticing that you want to change that are impacting your clients and yourselves as healthcare providers. And so with that in mind as well, there is a framework from the National Health system in the UK on sustainability and quality improvement. And quality improvement, once you do have a solid issue identified and you're starting to work on it, on quality issues, there are lots of factors that contribute to staff to make sure that quality improvement can be sustained and be effective over the long term. So all of the boxes in red are those factors that need to happen for quality improvement to work and for quality improvement efforts to work in the long term. And so hopefully something that's coming across here is that staff engagement at all levels is incredibly important right from the beginning all the way till the end, and at all different levels. So again, it's not just that one person who's in charge and accountable to long-term improvement. It's really the group effort of everyone working in an organization. And I won't go in detail in the next two slides, but these are the quality improvement team roles that we use, as well as the other healthcare sectors in the province. When we're talking about addressing a specific quality issue, it's important that a team is created to help drive a particular quality improvement project or initiative. Again, moving past that, it's one person's role or one person has this assigned to their role. It really should be a team of people that are focused on an issue. And the executive sponsor is that person in an organization who's going to be the person that is a champion for the work that's happening and believes in the quality issue that you're working on. So if you're working on wait times, the executive sponsor is someone that can help you do that work. They're not necessarily involved at an operational level, but they're there to help you overcome barriers to doing your quality improvement. The quality improvement team lead is another key person on a quality improvement team, and they're really all about making sure that the project management runs smoothly for a quality improvement project. The process owner is someone that's really responsible for the process that you're trying to improve. So I'll stick with my wait time example. If you're looking at wait times, this might be someone that works at reception because they're responsible for that intake and kind of moving clients along that flow path into services and programs. The improvement advisor would be someone in your organization that has quality improvement knowledge and expertise. They're not necessarily an expert in the process, although they might be. They're more there to help you use quality improvement tools and methods to guide your work. And then finally, the QI team members, which can include staff and clients and family members as well, are those that touch the process on a regular basis and can really help you get to those root causes and think about meaningful change ideas that will impact that quality issue that you're trying to address. And so thinking about the myth of limited time and resources, we wanted to draw out and dig a little bit deeper into that myth in terms of what that means for the quality or the data side to quality improvement. And so on the right-hand side of the slide, you'll see that one of the key questions for the model for improvement is how will we know that a change is an improvement? And this question is really asking you about data. And what data you have, both quantitative and qualitative, that will help you, understand why something is an issue. So building off that wait time example, what are your current wait times before you started a project? Getting a really good sense of that at the beginning, and then as you work through the quality improvement process, it's all about understanding, are those wait times getting better as you're testing some change ideas throughout the organization or within that specific service or program. So data is really crucial to the model for improvement. But we often hear that, we don't have the data systems in place to actually do the data that's required for quality improvement. And what we encourage teams to think about is that we don't have to overly complicate data. It can be simple data collection, and it often builds off of systems that are already in place within your organizations. And we know about those limitations that community providers have, but it's about working with what we have to try and figure out how we can collect data and understand our systems better. Another issue that we come across is that we don't have long-term data sets that we can draw on to figure out a baseline. So those wait times, maybe we only have data for a year or two. We don't have them going back farther than that. And for quality improvement purposes, that's okay. We're really just trying to see what you have. Some projects we work with, there isn't a whole lot of baseline data, so we ask them to collect things over a couple months, and that's just what we have to work with. And that's fine. And the third point on this slide is really talking about the need to plot data over time. So, taking that simple data points into consideration, we do need to plot things over time, and we use run charts to do that, and we'll show you some examples of that coming up. But really, that's kind of the step between some of the data that we already have and how to make that useful for quality improvement is really to plot it over time, and it can be done in simple ways to do that. So this is a slide on what good data collection is for quality improvement, and I've touched on a lot of this in the previous slide, so I won't go through the list here, but good data collection for quality improvement is thinking about what you need to know if you're, what your problem is and what you need to know if you're making improvement. It's simple, it's cost effective, only collect data points that are relevant to the project that you're working on, and try not to overcomplicate data in QI work. And this slide speaks to that point as well. If we collect too little data in quality improvement, it can reveal nothing, but if we collect too much, it often becomes overwhelming and confusing for people. And so by too little, we mean, again, using that wait time data. If we're collecting wait time data on an annual basis, or even on a quarterly basis, that's probably not frequent enough to let us know if any of the changes that we're testing to see if we're impacting wait times is actually making a difference. So perhaps we need to bump that up to, either weekly or monthly wait times to see, what our change ideas are having an impact on. So that's just an example of something for you to consider. And as you're doing quality improvement work, it's trying to strike that balance between too little and too much information. And so this is an example of a run chart, and we'll show another one in a little bit as well. But just some things to note here to try and kind of make the theory of the previous slides kind of come to light for you a little bit, is that there's a few things to note here. So the first is that this team was looking at attendance rates for the Clubhouse program that they deliver to their clients. And so they wanted to make improvements on those attendance and the participation in the program because they had noted that attendance was going down. And so this group decided that it was the useful data was on a weekly basis to see if any of the change ideas that they were making were actually making an improvement. It's also good enough data. So, there's the potential here. So if we think hypothetically, perhaps, to capture this data, clients are asked to sign in. And so there might be some data quality issues that come with that, and in terms of if someone forgets to sign in. But this group really decided that, this is the data that we have. There may be some things that we can do to improve that data quality, but they took what they had and they went with it from the beginning. And another thing to note here is that this data collection was something that was already happening likely before this project started, and it's fairly cost effective, and it's not overly complicated in terms of getting the information that they need to understand if they're actually making an improvement on this issue. And so just last kind of slide on this issue is some data collection tips. So make data easy to do. So try and, again, not overcomplicate the data collection piece. Make it easy to do. Be sure to test your data collection tool with those that are going to be asked to collect it. So it doesn't have to be, fancy Excel spreadsheets to collect data. They could be simple tally sheets that you're using. And again, that good enough data rather than perfect data. So we're looking for good enough in terms of quantity and quality, not perfect data sets. And to agree on operational definitions in advance. So making sure that people understand, where your numbers are coming from and what they actually mean. And on this slide, we just give a good example of something that can be done. So I'm sure you've all seen these before, but in restrooms, sometimes they ask you to rate the cleanliness. And you hit one of those four faces to indicate, what you felt you experienced in the restroom. And so this is just a really easy way for people to let you know, again, kind of not overcomplicating the issue. And so we're going to pull up a poll, and there'll be several options, so we might take a few, 10 to 30 seconds for you to read through them. But we're going to ask you about data over time. And so poll is open. So I want you to think about, do staff and board members receive information about client satisfaction over time? And what about wait time? So do you get data on your wait times for your programs and services over time? And ask yourself about client satisfaction as well. And so we ask these questions because client satisfaction is something that we often work with teams as well as wait times. And it's just helpful for us to know what you're doing. So I'll give about 10 more seconds. Okay, so we're seeing that about 33% say that we look at client satisfaction data, but not over time. 8% of you are saying that you look at wait time data, but not over time. 75% say that they look at satisfaction data over time, which is great. And 31% say that they look at wait time data over time as well. So that's really great to know. And for those that either aren't sure or you're not looking at those data sets over time, we encourage you to start to think about how you might do that. And for those that are doing it, that's really awesome to see. And yeah, that's nice to know about. Okay, so I'm going to close the poll. And I'll pass it back to you.
Okay, thanks, Jenna. It's so important about the point around data and keeping it simple. There was an example that was shared with us when we started with the IDEAS program, and the example was that there was a desire to look at no-show rates at a clinic where clients were walking in for scheduled appointments, and the data coach developed a very elaborate Excel sheet that the receptionist could use to capture no-shows on this Excel template, and then it could be uploaded. And at the end of the week of trying this, the data coach went and discovered that there was actually nothing on the Excel sheet, and asked, oh geez, I thought we were going to capture no-shows. And the receptionist said, well, you didn't notice, I guess, the jar of marbles on my desk. And what she had been doing was every time somebody would no-show, take a marble out of the one jar and drop it into an empty jar, and at the end of the day, count them up to see the no-show rates. So again, very, very simple, and sometimes we can overthink things and try a convoluted Excel or data system to capture these things when it may be as simple as having a jar of marbles on the desk. So simple can be very beautiful. So back to our Clubhouse example and working through our next quality myth. So at LiveWell Recovery Services, client surveys are being completed annually and results reported back to staff and to the board, but no trends or comparing one year to the next seems to happen. Client satisfaction scores indicate a high level of satisfaction with programs and services offered by the agency. So that's good news. They have also been tracking the number of visits and number of clients seen as per their MSAW agreement with their funder, and are always working to make sure they meet these targets. The staff believe the efforts to meet targets are ensuring they are providing quality care to clients. And so I love this one because I think it's one that we may see quite a bit. And the myth here is that our services are high quality as you regularly review our internal processes and procedures, ensuring compliance with standards and funding requirements. So we'll bust that myth up a little bit too, and make a bit of a distinction between quality control or quality assurance and quality improvement, and it's really the latter that we're talking about. Quality control is really looking at compliance with standards or procedures, policies, and often measured at an individual level. So, for example, if we are, the standard is that we see 6 clients a day, then our quality control would be, let's make sure that we're seeing 6 clients a day. Quality improvement, on the other hand, is action-based and continuous. It's about understanding where there are issues to client care and working to properly diagnose the issue and test impactful change ideas aimed at targeting the root cause of that issue. And so quality improvement is very much aspirational. It's about looking how well we're doing relative to the provision of service, and again, thinking back to those domains of quality, and looking at how well we're doing and where are the opportunities to improve. Quality control, on the other hand, is very much concerned with weeding out those bad apples. Looking at a standard, or maybe it's an MSAW agreement that has a requirement, and making sure that we're complying with that or meeting that target in our MSAW is not the same as quality improvement. Quality improvement's really, again, it's what matters to our staff and our clients, and it's that continuously trying to seek to be better. And so some distinctions between quality control and quality improvement. A lot comes down to the motivation. Quality control, again, is motivated by measuring compliance with a standard. Quality improvement, on the other hand, is continuously improving a process to meet or exceed standards. The means to accomplish either quality control is often through inspection, looking for where we're not measuring up to that standard, and quality improvement is oftentimes about prevention, and that can be system redesign or improvement. There's also a difference in attitude relative to quality improvement and quality control. Quality control is often looking at what's required. It can be quite defensive if you're telling folks they're maybe not measuring up to a standard, versus quality improvement, which is very much proactive. It's much more of an inclusive attitude as well, I think. And the focus is different. Quality control is focused on the individuals. Quality improvement is focused on the process or the system that we're functioning in. And there's a great quote that every system is designed to get the results that it achieves, and that's sort of a fundamental principle of quality improvement. And also the difference in scope. Quality control is very much looking at the care provider, and quality improvement is looking at client care and that experience. And we'll kind of harken back to that several times, that it's really about that experience of care. And again, a difference relative to responsibility. Quality control is looking at the few. Quality improvement is really looking at all. And I'll also go further to say that there's, I think, often a confusion between data quality and quality improvement. And data quality typically focuses on that quality control. So it's looking about, are we meeting a standard in terms of our documentation, or getting all of a tool completed or documented, and is it documented well according to a standard? Those are very much issues of quality control. Versus, again, it's that quality improvement is where are the opportunities relative to client experience that we may be able to improve. And so we'll ask you again to take a quick moment and answer this question. So what are some quality control practices, again, not quality improvement, this is a bit of a test, I guess, that you are involved in with your agency? How do you determine if you are meeting standards and or funding requirements? And if you could just type your answers or thoughts into that chat box, that would be very helpful for us. give folks a moment to do that. So we have folks saying file audits, accreditation, yeah, those are great examples. Counting resident days and number, I'm assuming number of client interactions, accreditation, yeah. Are we meeting LIN performance targets? Yeah, another great example. Yeah, those are all no tenant contacts. Yeah, that's a good one. Or number of tenant contacts probably. Counting visits, number of unique clients, file audits, benchmarks. Yeah, those are all great examples of quality control. And we want to make a point too that quality control is not non-important. It's very important that we meet those targets or that we adhere to a standard. But we don't want to forget about that quality improvement, that aspirational goal to try and look at those opportunities to improve and work collaboratively to do that. So thank you for your suggestions on that. I'll turn it back to Jenna.
Okay, so the next scenario is all about the fictional agency staff all being trained on a new standardized client management system to complete assessments and also to complete client documentation. And so by implementing this new tool, the staff believe that that this will lead to improved client care because there's more standardization being promoted throughout the organization. And so the myth here is that we have recently implemented a standardized data collection tool we use with all clients, which will lead to improved quality of services, programs, and improved client outcomes. And so this is, again, something that we hear a lot in terms of implementation of a new tool or a new process, and how there's a belief that will lead to better client outcomes, which is really what quality improvement is all about. But implementation of a new process or tool are important. Much like Mike's point to quality control, it's important to standardize the way that we're doing things and to use tools that will help clinicians do their work better. But that doesn't necessarily mean that these tools and processes will lead to improved client outcomes. There are things or activities that you do in your agency to ensure smooth operations. So, for example, the implementation of a new data system, the implementation of a new assessment tool. But for the most part, we do call these non-value added steps. And what we mean by that is that it's non-value add from a client perspective. So it's those steps that are important to do your work and to do your work well, but they're not necessarily something that the clients value from their services from you. And so QI is really all about those processes that the clients and family members experience. It's all about improving their health outcomes and thinking about what are those value-added steps and what are those value-added aspects of care that clients care about that we can really focus on. Not to say, again, that those administrative or kind of behind-the-scenes work that you do is not important, but quality improvement should always have the focus of improving client outcomes and experiences. And so there's often a focus on measuring implementation projects. So, are we doing our work according to the policies, processes, standards, requirements that are put in place? But there's not that measurement in terms of, are these policies, processes, standards, and requirements actually impacting client outcomes in a positive way? And so the model for improvement encourages us to start small and then to roll out into those larger implementation projects. So we start small with a very small change idea. So for example, a change idea of how to impact wait times. Perhaps it's something around, client contact and how to shorten that part of the process. And then, once we find that those change ideas are actually working, you slowly roll that up into testing things with more clients and more providers. And then you work your way up to full implementation of a new way of doing things. And you think about ways to hardwire that change into your service.
Thanks, Jenna. So I'll address the final QI myth of the day. So at this point, our folks at Live Well Recovery Service have completed a QI project regarding the need to enhance the ability and understanding of clients to make a formal complaint regarding their care. Since the improvement project began, client complaint numbers have been increasing, and the reports of clients understanding how to make a formal complaint have remained higher than when the project started. These positive outcomes have been observed over the period of 6 months. Staff leading this project believes they will need to continue to measure these outcomes on a monthly basis to ensure momentum on this quality issue for the foreseeable future. So this is a pretty good one, and we've experienced it with some of the projects we've been coaching. And the myth is that we have worked on one quality issue and have achieved success. We must continue to measure outcomes on an ongoing basis to ensure sustained change. So we'll bust this last myth a little bit, and that is that QI is about testing, as Jenna said, small tests of change first, and continuously building these tests once we know that it is working and that the changes are leading to what we want to see. Improvement efforts should always evolve as quality issues arise that are important to the organization to address. And further to that, quality improvement plans are tools used across healthcare agencies in Ontario that define annual quality issues and likely change every year to include a few priority quality issues. And they're meant to be to always evolve over time as new quality issues get identified. And ultimately, some changes need to be monitored longer than others. Quick change cycles are exactly that. They're quick. When sustaining a change, it may be important to look at the data again on a yearly basis or some realistic timeline down the road. So when we experience improvements, and we have demonstrated improvements using things like a run chart that Jenna briefly showed us, we don't have to measure those forever. It's important to reprioritize and look for new opportunities for improvement and not stay stuck on one project once we have a demonstrated sustained change. But maybe just keep an eye on it from time to time, go back and check the data. Hopefully, as we mentioned, data collection is something that's built in or hopefully automatic within our data system that we can go back maybe on a quarterly basis or yearly basis and check in on that project. But if we've experienced a long-standing improvement, it may not be necessary to continue to measure that on a weekly or monthly basis. And I'll share just one from our examples in E-QIP. We worked with a team last round looking at hand hygiene compliance rates within the agency, and the team did a fantastic project to improve that. And we looked about a year later, and they had 4 indicators remaining on their quality improvement plan relative to hand hygiene. And so sometimes it's okay to, if it's no longer a priority, to move on, and that's fine. Find other priorities. Hopefully people can still see my screen. I was having a little flickering, but I think it's solved now. So this is an example from another team that we worked with, CMHA Middlesex, who was addressing challenges regarding wait times and made a massive improvement, as you can see on that run chart, around April 2017. And you'll see that issue of waits is no longer an issue. So maybe it doesn't need to be tracked, and we can move on to other priorities, or maybe we track it and visit it periodically, but not necessarily continuously on a quick cycle basis. And we can revert to our run chart rules, one of which is when we see a shift in our data, which is 6 consecutive data points on one side of the median or the other, and we see that as a signal of improvement over 6 months or 6 data points. That's telling us that our change has made an impact, and there is an improvement. So we can start to plan on maybe looking at other priorities as well, and knowing that we're confident that that has been an improvement. All right, recognizing that we're a little bit over time, but we'll carry on, and I'll let Jenna wrap up the session.
Okay, so I encourage you, if you've thought about any questions that you have on anything that you've heard, to please type them in the chat box, and we will stay on the line to answer them if any come out. If they don't, feel free to contact us. We'll pull up our contact information at the end of the webinar. But just to wrap things up, just some kind of key takeaways for you to consider as you move forward with QI in your own settings. And something that we hope has stuck with you is that quality improvement is something that can be done by all organizations and staff, regardless of resources. So there was a lot of information presented, but hopefully that was one takeaway. Starting small is really a key factor in this, and thinking about where to start is important if you do have limited resources, and that you don't have to take on a really big quality improvement project. It is really about starting small. Quality improvement is also client outcome focused and client experience focused, more so than it is looking at process or implementation of a tool or a new way of doing things. It's about what clients are telling us to focus on and measuring outcomes and experiences and gauging if we're making an impact on kind of those key aspects of client care. It's also not just about willing to do quality improvement. So there's a lot of I wouldn't say a lot of organizations, but there's a lot of good intentions out there to do quality improvement. But once quality improvement work starts, a lot of issues often come out. So when you're properly diagnosing an issue, a lot of things often come out that are may flag other issues that you hadn't noticed before. And it's really about owning up to those issues and thinking about creative ways to address them. So it's about being open to seeing your warts and all is something that came out of our team when we were having a discussion on kind of how to frame this issue. And all quality improvement projects do take time. So there are those things that we can do to start small, and if we have limited time, there's still things that we can do. But we don't want to sugarcoat things and make you believe that quality improvement can be done with really limited time. It will take leadership from organizations to set a time aside to actually do quality improvement and build that culture. And building that culture is really important, and that's really the piece that doesn't happen overnight. It does take commitment and dedication to looking at quality and thinking about how to improve client outcomes on a continuous basis. So that's kind of the wrap up for today. The next few slides are really looking at ways that you can get involved in E-QIP and continue learning about quality improvement. So this is a slide on our monthly webinar series. These are all the webinars that we've done in the past, and they can all be found on our YouTube channel if you're interested in learning more. You can also join our mailing list to learn about when the webinars are happening, as well as some training opportunities that are coming up. We have a open foundations program. So it's a foundations one-day program on quality improvement for those working in community mental health and addictions, happening in Toronto on September 19th. So this is for any organization and staff within those organizations that are interested in learning more and getting that foundational knowledge if that's something that you need. The space is limited to about 30 people. So if you're interested in this, we do encourage you to sign up soon. There's also the Advanced Learning Program, or the ALP, from the ideas that was discussed earlier in the presentation, that are accepting applications for projects that include more than one organization. There's 5 spots being earmarked for community mental health and addictions, and the applications are due in September. If you're interested in this, we do encourage you to reach out to the E-QIP team, because we can help support your application process, as well as there may be some subsidies available for your participation in the program as well. So we encourage you to reach out if you're interested in doing that. We also have a current cohort of projects from the E-QIP team coaching side of things open right now, and those applications are due to us by July 15th. We do have some priority areas that are listed there, but if you have other quality issues that you want to work on, you're more than welcome to send in an application as well. And again, please reach out if you have any questions on that, or if you need help doing your application, we're around to do that as well. We have an online community of practice where all of the information today will be stored, so you can get access to the slides there. We'll also send you a follow-up email this afternoon with the slides in there as well. If you're so inclined, we do try to encourage people to have conversations on that platform. How to sign up will be included in the follow-up email. But if you want to continue this conversation, we encourage you to post a takeaway learning that you learned from today, perhaps something new or a new way of looking at things that you didn't consider before. And this is a list of our E-QIP team members, our data and QI coaches, as well as Ashley and myself, who manage the program side of things here. Mike and Debbie are the directors of the program and are always willing to discuss quality improvement with you, and their contact information is here as well.
I was also going to say, with respect to the community of practice, if there's any questions, because we did run a little long today that we didn't get to, and you have, please hop on the community of practice and post, and we'd be happy to respond. Or if there's any QI myths that you're wondering about, or the difference between quality improvement and implementation, or whatever it is, feel free to throw it up there on the community of practice, and we'll engage in some conversation.
Great. So I don't see any questions coming through here, but there's other ways for you to do that, as Mike just mentioned. You will get a follow-up email this afternoon where you can do an evaluation for the webinar today to let us know how we did, and we also asked your thoughts on any future webinar topics that you're interested in learning about, so we encourage you to do that. And so if there's no questions, we just want to thank you for joining today, and we look forward to connecting with you again soon.